Hello everyone and welcome back to the Ideal Nutrition Podcast. My name is Torwen and I'm joined today by my co-host Aidan. Our episode today is all about SIBO, or Small Intestinal Bacterial Overgrowth, and what the evidence says about it.
So where should we start with? Should we start with...
Let's explain what SIBO is.
Yeah, so small intestinal bacterial overgrowth is it's based on the concept that most of the bacteria should be theoretically in the large intestine and there shouldn't be much in the small intestine. And this overgrowth occurs when it is clearly in there, when there is much more of it that is in there than necessary, and often that can cause issues, which is why it is a condition that we care about.
So this overgrowth of bacteria can lead to digestive symptoms, things like abdominal bloating, excessive gas, flatulence, which is normally caused by that bacteria fermenting the carbohydrates in the small bowel, abdominal pain, cramping, different bowel movements, either diarrhea or constipation, excessive feelings of fullness, and maybe nausea as well.
And one of the reasons we're starting with what's evidence-based and what's not is there's no gold standard diagnostic criteria. And that also means that the prevalence rates are incredibly varied in terms of what is being reported. There's a lot of overlap with IBS type of symptoms, and I personally have seen stats showing that somewhere between as low as like 10% of people with IBS have it all the way up to like 80%. And if it's as high as 80%, that becomes very, very interesting. If it's as low as 10%, that's still relevant and there's still stuff we can do with that. In terms of like numbers I've gone through meta-analysis type of data, so I've put some of that in the show notes, and also I've looked at a lot of other stuff, and some estimates look along the lines of, in quote unquote like healthy controls, so people who are not meant to have SIBO, we see 2.5 to 15% of people having SIBO based on like the closest we've got to standard diagnostic criteria. It seems to be far more common in people who are older as well. In people with IBS-D type symptoms, the closest I've seen is around a 35%. That's the closest to a consensus. As I said, there's a huge range. In people with diabetes, 30% seems the standard kind of estimate. Celiac disease, around 20%. And in IBD, 20 to 30%. And one of the pieces of logic there is particularly if they've had prior surgery, that could have led to some strictures that could increase the risk of this.
Now that's a significant portion of people with gut disorders or other disorders. So I found very similar numbers and breath test diagnosis showing about that 20% prevalence. Should we talk about how it's diagnosed, or should we talk about what can cause SIBO?
I reckon we go with what causes it. And there's two main mechanisms, I'd say. So the first one is what you call impaired motility, which is like things going through more slowly, and it gives the bacteria longer to quote unquote anchor and then like multiply, reproduce. So if things are moving through the small intestine slowly, there's more time for them to kind of grow in that area. The other angle is low stomach acid. So that would normally kill certain bacteria prior to reaching the small intestine. And there's also other angles where like it could be coming up from the large intestine as well, the other area. And in addition to like the slow motility, there could be times that there's like literally like physical blockages and stuff like that can contribute to this, which is where the abdominal surgeries come into play as well.
So this kind of makes it quite clear that SIBO is generally considered a secondary condition. So it's something that occurs when there are other symptoms occurring in the body, or your body isn't able to do its natural processes, protective mechanisms, that sort of thing. So we want to identify what has happened first. That's sort of the first step of SIBO identification, you could say.
Yeah, absolutely. In terms of how it's diagnosed, as I said, there's no gold standard. It'd be so much easier if there was. So there's two mechanisms. We've got breath testing, and we have something called a small intestine aspirate. Both of them have pros and both of them have cons.
Yeah, both tests have flaws. We'll explain what both of them do. So breath testing is a hydrogen methane breath test. You drink a mixture of glucose or lactulose, and then they measure the amount of hydrogen or methane in the breath. A rapid rise in either indicates that there is that bacterial overgrowth. The issue is that this can give a false positive quite frequently. Lots of things can affect the result, as in what you've eaten beforehand. If you've brushed your teeth, if you've got fast transit naturally, that might mean that reaches the bacteria quickly, and that can cause that false negative.
Yeah, so specifically, like it could reach the large intestine quickly, and that's like completely healthy, completely normal, but that would show up as a false positive. One of the key things I'll note is that 30% of healthy controls in a review showed positive on a lactulose breath test. That's just a huge false positive rate. And that's why that's a huge flaw in it, right? The other test is the small intestine aspirate test, which basically it is far more directly measuring the presence of bacteria rather than just their gas byproduct, but it is more invasive. So it involves an endoscopy. The patient obviously needs to be sedated for a gastroenterologist to pass that tube into their mouth and then into the small intestine. A small amount of fluid is suctioned out, which is then sent to a microbiology lab to see how many bacterial colonies grow. So that's far more invasive as well. And it still has flaws. So one of the flaws I've seen people talk about is that it could, quote unquote, pick up hitchhiker bacteria on the way through to getting to where it's going. The second one is that SIBO isn't always spread evenly. So you might be getting it from like, quote unquote, a clean spot that doesn't have much bacteria, but the overgrowth is like slightly further down or slightly higher up or something like that. So that would give it a false negative as well. Other people point out that many gut bacteria die when they're exposed to oxygen. So even in the handling process, sometimes like that can mess with it as well. So because it's like more invasive, requires sedation, like the risk to reward ratio is often considered too high. So what I have seen from a lot of practitioners is they're far more likely to do the breath test and may or may not just acknowledge that it has its flaws as well.
Yeah. And even with that small intestine aspirate, like you said at the very start, you're going to have to find a gastro who is willing to do that and believes that SIBO could be the root cause of issues, which may not always be the case. How is SIBO managed?
I reckon there's one more step in the diagnostic process I want to talk about, because if we're going with the, like what's evidence-based and what's not, there are some people who will very, very willingly use the breath test and use that as the be-all and end-all, as we can see that there's like the flaw of it having too many false positives. How do we improve the odds? Because it seems like there is no gold standard because there's nothing that's like a perfect diagnosis. But say a gastroenterologist is looking at like improving the odds, they could add blood testing, which could be looking for like certain vitamin deficiencies associated with this. They could look at stool evaluation to test for fat malabsorption. They could do imaging tests to look for structural abnormalities. So this could be x-rays or CT scans. And there's another variable that could be like based on certain medications that are linked with this. Like, are they more likely to have low stomach acid because of certain medications too?
Along with maybe just a clinical evaluation of whether they potentially have post-infectious IBS. Is there anything else that's gone on in the background too?
Cool. How it's managed?
Let's chat about it. So antibiotics is definitely the first line approach for SIBO. Rifaximin or neomycin are the two that I've found that can have quite high success rates. What are your thoughts on those?
Yeah, so that's definitely what I consider frontline. So in terms of the effectiveness, what I saw in research was they have about a 60% effectiveness in terms of normalizing breath test results, which even then you're like, well, that's not incredible. 60% from antibiotics isn't incredible, but that's still good, or a step in the right direction. One little issue is that it seems that around 45% of people have a recurrence of SIBO in about 9 months of within 9 months of the antibiotic use. And obviously, as everyone knows, there are downsides of doing antibiotics, particularly repeated cycles. So that then leads to people pointing to being like, you've got to find the root cause. Like this could be the frontline treatment, but there's ideally other things you can do if it is recurring as well.
And again, just to bring it back to what that could be, is it PPI use causing low stomach acid? Is it slow motility? Or is there any other gastro issues going on that could be causing this? Diet strategies then can be sort of linked in with antibiotic use, and that's something that I would probably recommend. Let's talk about the low FODMAP diet first.
Yeah, let's start with that one. So that's definitely the first one I see a lot of people pointing to. The low FODMAP diet is a diet where you will be avoiding/minimizing fermentable forms of carbohydrates. So there is a list. We've got heaps of content on this, so it's pretty easy to find like what the low FODMAP diet is. It's also typically not something you do long term. There's like reintroductions and stuff like that. It very clearly can and will help with symptoms, particularly if some of the symptoms are the IBS type symptoms in terms of specifically bloating, because obviously if you have less fermentable forms of carbohydrate coming in, there's less fermentation, that should lead to less bloating and less gas build up. It might help reduce overgrowth a little bit because it gives them less to feed on, but there isn't heaps of research on that supporting that. It's also very clearly like not a treatment by itself. Like as we were speaking about off air, it's something that a lot of people often find like some improvement, particularly early on, but it doesn't seem to like solve everything.
Yeah. I want to lump one in with that because I have had a client come to me that did very low carb carnivore style diet, which has a similar, I guess, idea behind it. So the idea here again is that you eliminate carbohydrates, which starves these bacteria and takes away that fuel for them. So that's sort of the thought with low FODMAP, low carb carnivore style diets, but they're not long term. It's very important to do the reintroduction and personalization for longer term gut health.
Yeah, and in a way, the low carb/carnivore is just like a simpler way of doing it. Has other flaws as well. Did you see the elemental diet and stuff like that as well?
I have, yeah. So that one's a little bit different though in the fact that you take your food with a pre-digested liquid formula for 14 to 21 days with the idea that all the nutrients are absorbed within the first few centimetres of the small intestine so that the bacteria which are further down have nothing to eat and will starve. It's not something that I've commonly seen being used in practice, and maybe that's because it's expensive. I don't really know how you would access it and whether it even makes your food enjoyable.
Yeah, absolutely. So those are the barriers. So one study I saw found a greater than 80% success rate in terms of normalizing breath tests, which raises the obvious question of like, well, why isn't this like the common practice thing? Firstly, I never think we should overreact to one study. Like, it's not like we have heaps and heaps of data on this, but what we have looks quite promising. It also makes sense. It is this logic of quote unquote starving the bacteria because it's all digested before it gets to most of this bacteria or where it's very likely to be. So technically, based on that data, it looks more effective than antibiotics, which would make you think, why don't we just do that, right? Downsides, it is a bit expensive. I looked into how you get it, and you can just order this stuff online. It doesn't seem super popular, but you can, like if you looked up an elemental diet, like you can get the powder that you then turn into liquid and so on and so forth. It apparently tastes terrible. Like palatability was what the word that was used, and it's just not very commonly used. But I do think it's interesting to know that it exists, particularly if you were in a position of you'd done the antibiotics and it had recurred and you couldn't find any quote unquote root cause or anything like that. It is another interesting option as well.
And 14 to 21 days, if you can have food that tastes terrible for that amount of time and get rid of symptoms, maybe it makes sense. Especially, 80% compared to 60% success with antibiotics is huge. With that, let's chat about probiotics, which is maybe a bit more of a controversial aspect of nutrition or diet strategies. But the reason it's controversial is because people argue, should we add more bacteria in when there's already an overgrowth of bacteria in the small intestine? That comes with a few things, and I think we've popped this study in the show notes, but a meta-analysis study has shown that certain strains can help. So I'm going to absolutely butcher this name, but Saccharomyces boulardii and Bacillus clausii can help clear SIBO and improve the symptoms, maybe even helping with that effectiveness of the antibiotics. But people who took the multi-strain, broad-spectrum probiotics have actually reported that it increases the abdominal pain and the bloating.
Absolutely. And that review also found that like it's worth possibly considering timing as well. So like in practice, sometimes I'd consider it like using the probiotics right after the round of antibiotics to quote unquote help restore the balance and potentially help prevent recurrence. So like I lean in favor of probiotics being worth doing. Like I don't once again view it as something that's absolutely going to move the needle heaps, but it is a little step in the right direction, I would say. So key takeaways. On my end, I think that the lack of diagnostic criteria makes this a very difficult space to interpret. And it also makes it a difficult space to get help in many cases as well, because there is very valid like hesitance around like, should we go down the route of testing for this? Particularly even if we go down the route, we don't even know for sure that this is what it is. There's also so many other potential things that this could be, but it's worth being aware of for sure. I can see why people would be hesitant to over-diagnose it. It still is a legitimate condition though. Going down the management path, like how I would probably look at it is I would actually do the antibiotics first, but like I would see logic in either doing antibiotics or an elemental style diet if you wanted to do that as well. Step 2 is try to find the root cause and address if relevant, particularly if you are on proton pump inhibitors, so you have low stomach acid or anything else causing that, particularly if you have other surgeries. So like one of the things is that if there is a blockage that's been caused by previous surgery, sometimes people get a surgery to fix the blockage as well. So trying to look at that root cause type of thing as well. And I view probiotics as optional, but I would personally consider having them as well.
I think that pretty well covers most of my thoughts as well. I think if you're a clinician listening to this and maybe you're not super familiar with SIBO or you haven't come across it as much, definitely using the combination of your clinical reasoning along with test results, given that those test results can give so many false positive results.
Absolutely. Well, this has been episode 241 of the Ideal Nutrition Podcast. If you haven't already, if you could please leave a rating and review, we would massively appreciate that. But thank you for listening as always.